to SARC Talk. SARC is a nonprofit cancer research organization that develops and manages clinical research trials in pediatric and adult sarcomas. SARC Talk is a podcast to discuss activities of SARC, interview sarcoma research leaders, and review scientific initiatives in the sarcoma field.
Welcome to SARC Talk, episode 26. My name is Scott Okuno, a medical oncologist at Mayo Clinic and chief medical officer at SARC. At SARC Talk, we interview interesting people who are connected to sarcoma, where we can share and spread the knowledge about sarcoma. Today, our guest is Dr. Elise Nassif Haddad, assistant professor of the Sarcoma Medical Oncology at the University of Texas MD Anderson Cancer Center. She's also the assistant professor of investigation of cancer therapeutic at the University of Texas MD Anderson as well. Dr. Nassif did her training in medicine. Now, at least you're going to have to help me out here because these are very Frenchy words here. So I might butcher it a little bit there. But you did your medicine at Immunology University Descartes in Paris, France. It sounds like you also did a PhD as well, which is kind of fun to know at a different institution. That was the University Claude Bernard in Lyon. And then you did your clinical residency and fellowship in medical oncology back in Paris at Descartes. And then you did a research fellowship at MD Anderson. Is that fair
You
enough
did
to say?
great with the
Okay.
pronunciations of names.
Yeah, that's really hard. So, well, first of all, Dr. Haddad, thank you for being with us today. And for those that are listening here, Dr. Nassif Haddad's research and clinical interest is on leiomyosarcoma. And part of that we'd like to delve in today. So, Elise, thank you for spending time with us today.
Thank you for inviting me. I'm excited to be here.
Yeah, great. You know, we've been interviewing several people along the way here and having great conversations. And one of the things that we're always interested in is how does individuals get interested in oncology, yet alone sarcoma? And maybe you can share how you got interested in this field.
Yeah, sure. So I was always interested in rare diseases before I knew I wanted to do oncology. I just had a thing for rare diseases, mostly because as I was rotating as a medical student, I could feel how patients were hopeless and to get more information, and I just wanted to help. So I was into rare diseases way before I wanted to do oncology. And then I initially did med school because I wanted to do pediatrics, and then figured out that after 3 or 4 oncology rotations throughout my curriculum, I really found oncology to be super interesting. And essentially, the patient physician relationship I found to be really rewarding in oncology. And so I chose oncology to go into oncology. And very early on, so training is a little bit different because in France, where I trained, the residency is going to be directly choosing oncology. So we do some internal medicine rotations, but within our oncology curriculum. Whereas in the US, people do 3 years of internal medicine and then a fellowship in oncology. So we kind of do a combined fellowship residency of 5 years in medical oncology. So just after I chose medical oncology, just after med school, my second rotation was at Gustave Roussy, which is the major cancer center in Paris. And I met Axel de Seine, whom you probably know and a lot of people know. And I was in his rotating in his clinic. And, I think most of us end up choosing things based on the people we meet also. And he kind of took me under him and asked me to rotate with him more and to do some sarcoma, and then helped me through the whole French sarcoma group structure. And then I did most of my residency focused on sarcoma, which is not very frequent. And that also fit into my desire to do some rare diseases. It kind of like fit in all together.
Wow. Elise, can you share a little bit about, the decision? You said you started and thought you were going to be a pediatric, and you could have done a PT Mong. What was the decision point that says, no, I want to do adult medical oncology rather than the peds realm?
Yeah, really good question. So, I mean, I guess the training is also a bit different in France. So you would have to do full pediatrics and then do a fellowship in pediatrics hemonc. And I was not really interested in doing, after rotating through pediatrics, I was not interested in general pediatrics at all. So I just found, yeah, I was just not interested in that.
What's interesting, and you highlight something that I didn't know, is that when you did your medicine, it was really a oncology, internal medicine-y, focusy type of 5-year program. I suppose if you want to be a cardiologist, you had to do 5 years of cardiology, internal medicine type of thing. So that's interesting. So here you are, you somehow by luck got one of the world's authority in sarcoma under your wing, developing it, and it changed your career path. But more importantly is there's 100 histologies we can think about. How did you end up saying, I want to do a rare tumor, but I want to do one of the more common of the rare tumors, leiomyosarcoma? So
Yeah, that's, I mean, of course, it's like opportunities, how things get organized. So my PhD and my Master of Science and most of my postdoc was focused on immunology, on translational work in immunotherapy space. And so, as you know, leiomyosarcomas are not very responsive to immunotherapy. So initially I was doing kind of some both UPS and leiomyosarcomas, and then actually had the faculty position at Anderson, and it did seem like there was space in leiomyosarcoma, and I was interested in trying to develop immunotherapy which wasn't working and trying to find out why it's not working. So a lot of the translational work I do currently is trying to define why it's not working and how we could combine it with potentially other targeted therapies in order to make it work. And potentially, probably not with the current immunotherapies that we have, right? So that's the part where I'm also in the investigational cancer therapeutics department, the phase 1 program, where we look at other types of immune stimulating agents, and I try to see if some of those could make any sense in leiomyosarcoma. So it's more of the challenge of in a frequent though rare tumor, trying to make immunotherapy work. And I was kind of working on both the UPS and LMS, being those two are genomically complex tumors, yet one is more immune sensitive and the other one is really more immune resistant. And so that's how I got into that. Yeah.
got it. So you're out in France doing the things you enjoy to do. You thought it was great. Then somewhere along the way, you said, I want to go to the States and I'm going to go to MD Anderson. And maybe you can share your story of how that navigation happened.
Yeah, once again, meeting people. So I was doing my Master of Science in Immunology at Paris Descartes. And so I met Professor Friedman, who was one of my mentors during this Master of Science in Immunology. And at that point, I had already been doing my residency. So I'm like, I'm passionate about sarcoma and I'm doing immunology. And that's really the moment he was co-publishing the Nature paper on the TLS and the sarcoma immune classes with the MD Anderson group, right? So they were publishing those paper together on the TLSs. And I happened to be here doing immunology and saying, oh, in the clinic, I like sarcoma. And what Professor Friedman, who is one of my mentors over there, still is, told me is, there are not a lot of places in the world where you can do sarcoma and translational immunotherapy. And we're developing this collaboration. You should really think about going there for just like a year or so. And then he put me in contact actually with Christy Rowland and Emily King. Actually, Hussein Taubi, because they were working on the SARCO-28, right? And so Hussein was then pivoting towards melanoma, and he put me in contact with Dr. Rowland and Dr. Keung. And so they were working on their neoadjuvant immunotherapy trial, nivolumab with or without ipilimumab, neoadjuvant and DDIF lipos and UPS. And they just said, yeah, you can come for a year, work on the translational analysis of our trial. And then I'm with Jean-Yves Blais also at that point. He says, "Oh, I also have a neoadjuvant immunotherapy trial underway. So, you know what? We can make it a PhD. You work a few years on the French neoadjuvant immunotherapy trial, and you work with Anderson on the U.S. Neoadjuvant immunotherapy trial." So that's how things kind of like happened. And then I came here and just for a postdoc for 1 year. Then we figured out that I needed to stay another year because there was a lot of work. And so I stayed a second year, and then my husband and I were offered jobs at two different departments. He is a leukemia faculty now at MD Anderson while I'm doing sarcoma. So that's how then I stayed as faculty. That's what made the most sense for us. And I've been super happy here because the team here, as you probably know, is great. All my colleagues are really nice, and I've been very happy here. Yeah.
Yeah. If you would have said 5 years ago, would I do a couple years at MD Anderson and go back? That was probably the ultimate plan. And both you and your husband, when we chatted there too, it's like he loves it, what his job is, and you love what you're doing there too, which is great. Um, to that point, part of that is even though the sarcoma community is relatively small, you still got to know all the local politics, the logistics of navigating things, and in that aspect here. And um, the efforts that you have down at MD Anderson, because of the great strength of the trials collaboration that you already set up, and in the world-renowned relationships that you have with other organizations, how would you share your experience? And if you have a younger staff or junior staff coming through, what lessons would you tell them if they're not at MD Anderson of how to navigate it? Because everybody listening is not from MD Anderson, so the thoughts of that, because if it's a match made in heaven if you do what you did the way.
Yeah, I've been very lucky and very fortunate to have just amazing mentors all throughout. From great institutions. But I think although it might seem intimidating in the beginning, I will quote here. I'll quote Susan George, who told me this at actually the roundtable meeting last September. She was telling me, the sarcoma world, we're just nice people. If people want to do sarcoma and they come and they're like, I want to do sarcoma, then the answer is always, you're in. And she's right. The answer is usually you're in. I think there are job offers all over the United States and all over Europe. We just have too much work on our hands, both research and seeing patients. So I think that the key is to not be shy, and you'll find that a lot of everyone in the sarcoma world is very supportive of young investigators. And I think that's also one of the things that made me go into the field more and more is like I had Excel helping me in the beginning, but then every time I met with someone, had an idea, talked about with anyone really, even very world-renowned people, they would just support me and say, "Oh, what you're doing is so great. We want to help you out. We'd be very happy to collaborate." And so I think it's a very welcoming world. You just need to not be shy, but show up at CTOS, which is our big meeting. Show up at a few meetings and present a poster, present some research, look like you're interested and that you really want to help patients, and you're in.
You're right. And we've had other guests as well on this talk. And basically, it is a very welcoming community. It's not crowded. There's so much opportunity. There's not enough of us. So in order for us to move the needle anywhere, we have to be collaborative. And that's the part that is exciting from us. I'm going to go back just a second here. You're on staff now at MD Anderson. You are still doing immunology, you're focusing on LMS, and maybe you can share the collaborations that you are developing, continuing to develop and nurture at MD Anderson in that field.
Yes. So um, I think there are two types of collaborations. There are the ones within MD Anderson and those that we're building with other institutions and internationally. So at MD Anderson, we have amazing resources and a lot of collaborators. And it's been, because also I came in through the postdoc route, the research route, it was very easy for then when I transitioned into faculty for my clinical trials to actually already have the relationships I needed with the more translational labs. So for me, for example, one of my major mentors and supporters is Alex Lazar and all of his lab structure, which provides, incredible resources in terms of tissue-based biomarkers and research, because they have a biobank that is invaluable, of course. And we have monthly a leiomyosarcoma working group at Anderson, which meets an hour every month, where I try to invite different people to present what they're doing, because I'm not the only one doing leiomyosarcoma research, right? We have people in radiology, people who are more lab-based. We just recruited Yelena Garnero. She's really great. And we have radoncs. We have our, of course, our GYN colleagues with the uterine leiomyosarcomas, and we try to invite different people to be there and to speak and present their research. And, at the beginning, it was just Alex Lazar, Christy Rowland, and Emily King, my mentors, who are here supporting me and cheering for me for chairing that leiomyosarcoma working group. And it grew up to be something with really, on average, 20 to 30 attendees every month, not always the same people, with really interesting input on the research that everyone's presenting. So that's kind of like inside MD Anderson. And I recognize that because I came through the research path, initially being a postdoc, it's been easier for me to build those bridges between the clinic and the lab. Internationally, of course, as you know, being part of the National Leiomyosarcoma Foundation helps. Being in contact with other people and advertising that I am in that space. And so having people reach out to me just because I'm part of the National Leiomyosarcoma Foundation. Also, they see me at the meetings and at the round table every year. So that does definitely help. And then I'm nurturing my French collaboration, of course, relationship, which actually is not that easy because, as you know, nowadays DTAs across the Atlantic is a nightmare. So I'm very close to the French sarcoma group colleagues, but it's not as easy as I would like it to be in terms of actually collaborating through the research, really, and sharing data. And yeah.
Yeah, that's the next step because, as you said, that's how you got to MD Anderson because of that relationship. So now you're here, you got to do the reverse, and that's going to be a good thing. For those that were listening, you threw some good names out there, and one of them is the National Leiomyosarcoma Foundation. You used the word roundtable, which some people may or may not know about. And maybe you can describe what is the National Leiomyosarcoma Foundation and what your role in that organization is. And then we can then pivot to what the roundtable is.
Yeah, sure. So the National Leiomyosarcoma Foundation is both like is first and foremost a patient advocacy group, and also has a scientific committee that is actively trying to fund researchers who have good ideas, and meets regularly in order to define some priorities for leiomyosarcoma research in different ways. So we have the executive committee with our scientific board, which meets regularly throughout the year, every 3 months currently, and we try to define priorities for the different awards that are sponsored by the National Leiomyosarcoma Foundation. So we have career awards for younger researchers, and we have a grant that's funded every year, and everyone who's listening who wants to apply is welcome to apply. And so we are coordinating this. And then we have specific work groups that are focusing on some research questions with work group leaders in the National Leiomyosarcoma Foundation. One work group focusing on clinical trials, one on uterine leiomyosarcomas, and one currently mostly on preclinical work, which we call the omics and cell lines work group, and soon to be a radiomics work group focusing on the imaging of leiomyosarcomas. Um, we have a yearly gathering, which is called the Roundtable, the International Roundtable, in which we call it a think tank, in which basically during which for a couple of days, all leiomyosarcoma researchers are invited. We have presentations that we try to organize within the work groups so that they actually answer the scientific questions that we've set ourselves to answer. And we do invite different speakers who are doing other research within the leiomyosarcoma field, not within the work groups. So we try to gather interest in the leiomyosarcoma research space and potentially ask new questions. We also invite our awardees to be there. This year, we're going to focus on a consensus paper to try to define what are the challenges and the controversies in this space, and that's for the scientific part of the National Leiomyosarcoma Foundation. But also, very importantly, there's all the patient advocacy part, which I'm less part of. I'm part of the executive committee, but which is equally very important because it aims at educating patients on what the scientific community is thinking and what's the current treatment standards for leiomyosarcomas. What I think is really unique in all those patient advocacy groups focused on one disease is having both the scientific part and the patient advocacy part. What I like about it is the goal is to have the researchers and the clinicians define some priorities, but listening to what the patients are actually wanting us to define as a priority. And in the same way, us seeing that, there's some education to be made about XYZ topic, specific challenge currently, we can bring it back to our patient advocates and say, this is something that's important for patients to know about. And so there's this bilateral kind of relationship, which I think is very important.
Yeah, definitely. And Elise is kind of being modest there. She is the uh, what co-director of the executive team, so she has really taken over and really moved the needle of trying to, you know, house that research component across the U.S. and outside the U.S. in these working groups, formalizing the structure of how we review how the National Myosarcoma Foundation does provide grants, but she is able to get a group together to rigorously review those great applications and say which ones we love to fund them all, but you have to only be able to fund one, and then really gear our national meeting to the meets so we meet and greet and discuss things. And it's the foresight, I think, of Annie and Mitch Ashe, as you know, that's helped really move that along, and they're really focusing their main efforts now on the advocacy part, as you're right. And it's just a partnership for leiomyosarcoma. And Elise has really done a lot of great work in that space. And those that are listening, yeah, we have a meeting. Um, not in the United States this year. Where's the meeting? We have a collaboration with Spain as well. Go ahead, Elise. You're smiling. Yeah.
It's in Berlin. It's organized by Spain too, which is another patient advocacy group. So it's co-organized with Spain and with Bernd Casper and Fernando Augusto. This year will be just before ESMO in Berlin. So it's 17th or 18th of October, just the 2 days before the European Oncology Conference. And thank you, Scott, for your kind words.
It's okay. You talk about the strength that you came in from the basic science aspect at MD Anderson, but you have a great clinical multidisciplinary clinic at MD Anderson. And maybe you can share with our audience here how that kind of works and how that stimulates and fosters great patient care, clinical trial, and new ideas.
Yeah, I think we're really fortunate. So I'm going to get it wrong with the precise number, but I think if you look at the number of oncologists across radiation oncologists, medical oncologists, and surgical oncologists, we're like 30 something providers seeing just sarcoma patients. So it's incredible, right? So we're 12 sarcoma medical oncologists dedicated to sarcoma, and we're hiring. Anyone who wants to actually apply, you're welcome. But we're 12 sarcoma medical oncologists, and the sarcoma center in itself, we share our workrooms with our surgical oncologists, which are 5 dedicated to sarcoma only, and our ortho oncologist, who do mostly the extremity sarcomas and the bone sarcomas. I'm going to get the number of ortho oncologists wrong, so I won't quote it. And the radiation oncologists are in a different center just because radiation needs to be in special places. But we work closely with them too. But first of all, when we're in the clinic, we're actually all sitting together. So Christina Rowland, Dr. Rowland, who's section chief of the sarcoma surgical oncology program, is in clinic with me every Thursday. So if I have a quick question and I need her to look at the scans and we can brainstorm together, we just do it like every clinic. I don't think there's one clinic where one of us doesn't ask the other one, can you do this? What do you think? Which really is a great experience. Then we have multidisciplinary tumor boards twice a week on Tuesdays and Thursdays, and this is very well attended by our pathologist, our radiologists. We have our radiation oncologist, ortho, surgeon, and sarcoma medical oncology. The fellows come and they usually like it. We present our more complex cases, and I think it's a great place to really learn from each other. When we present our complex pathology case, I just learned so much from our pathologists during those conferences. Same from our radiologist. I learned how to read MRIs because this is still very complicated to me sometimes. So this also fosters collaborations. And then we have kind of a medical oncology, more dedicated a conference every week where we sometimes invite other surgeons. Oh, we have our head and neck surgeons also on multidisciplinary tumor board. Sorry. I shouldn't forget them because they're actually very important for a lot of our sarcoma patients. So we have all those different meetings and we just work a lot together. And in addition, when we're talking about research, we have those working groups. So I have my leiomyosarcoma working group. Dr. Sumaya has her liposarcoma working group. Dr. King and Dr. Rowland are chairing the UPS working group, and those do foster a lot of collaboration. The surgeons have a dedicated surgical oncology meeting every week, and I try to attend it to provide some medical input. So we have all those different meetings, and I know we all have meeting fatigue, but those meetings are actually really productive meetings. So, and they're very well attended because I think we learn a lot from each other in those forums. And I mean, we just have a huge group. And then last part of like how we're organizing things, as I was saying, we kind of have our working groups for research. In the clinic, in medical oncology, a lot of us actually kind of match our research to the type of patients we see. I mean, the type of disease we see. So while I still see any type of sarcoma patient, I would say 50 to 60% of my practice right now is focused on leiomyosarcomas, and the rest 40% is a little bit of everything. I don't see a lot of osteosarcomas because Dr. Livingston sees them, most of them. I see like one angiosarcoma patient a year because, one patient with angiosarcoma a year because Dr. Ravi sees all of our angiosarcoma patients. But we are not entirely differentiated, but quite well differentiated, which also helps with asking the right questions and our research endeavors.
Yeah. At least thanks for sharing because, many of us have one view of what a big multidisciplinary cancer center like MD Anderson is. And hearing all that collaboration, you can just imagine the quality of care those patients get. So I do, and helps us be excited, and anybody listening saying, I like to start a little bit of this at my institution or build on what they do, you can always talk to Elise, and the other members are always willing to share kind of, it might not work anywhere else but MD Anderson, but at least you got to think of what they're really putting out.
Yeah, absolutely. Please reach out. Me and all of my colleagues were super happy to help out and give insights.
Absolutely. To that point, there's a lot of great things that have happened, I think, in the LMS space in the last couple of years here. And I know there's still opportunities, but for our listeners here, what would you say are the one or two, three big key highlights that you would see that have moved maybe practice changing in leiomyosarcoma in the last year or so?
Yeah. So the one thing, the biggest thing that's practice changing, I think, is the recently published LMS-04 trial, which was comparing adriamycin trabectedin for 6 cycles, followed by trabectedin single agent for a year, compared to adriamycin single agent in first-line leiomyosarcomas. So I think this was a phase 3 randomized clinical trial, and it definitely changes practices because it does show an OS benefit of 11 months, so overall survival benefit of 11 months for patients with advanced leiomyosarcomas. So there's a lot of debate about how to integrate this actually in our practices. So I'm not going to go into the debate because it, this is an ongoing controversy and there are other trials ongoing too. But I think undoubtedly, whether your critique or not of this data, the one thing I think everyone can take out of this data is I actually think that the number of patients to whom we should be giving adriamycin single agent for leiomyosarcomas for treatment of advanced leiomyosarcoma first line is very limited. And I think that is something most people would agree with in the sarcoma field currently. There are still patients, of course, who could not tolerate, and especially the combination with adriamycin trabectedin. Like, it is a tough regimen and it's not for every patient. But I think that adriamycin single agent, with all the data we have, and the data was published by the Europeans, retrospective data with the dacarbazine, tends to show that at least in the leiomyosarcoma space for first line, adriamycin single agent is reserved to only patients who really can't tolerate combinations. For me and our practice at Anderson, we actually have adopted the adriamycin trabectedin regimen fully as a first-line regimen. We're thinking of moving it towards the perioperative setting. We're actually doing it also in select cases. And I think this is a regimen that's effective. I am very excited by the upcoming adriamycin lurbinectedin, which is this new other molecule data, because it might prove to be less toxic with the same activity. That's the hope. But I think those combinations are going to move forward into being in standard practice for a lot of people. It for me, it's the major paper in the past couple of years.
Yeah. So those that are listening, LMS 04, and it's really set the mark that a doublet at this point is still has a survival benefit plus maintenance. They throw maintenance in it. There's still a lot of questions, debate, tension about the right sequencing of the schedule of the trabectedin, et cetera. But the reality is, I think in modern day today, based on that study and potentially studies that are coming out with the carbazine, retrospectively, that a doublet is probably going to be the first line for most patients that can tolerate it for survival. You're right. And as you said, you're starting to move that up earlier and that and we would love to see the Lurby data too. So we'll have to kind of wait and see. So I think, a lot of us have waited and waited and waited. It says, where is the biggest leap forward in sarcoma? And I think right now we can probably with a straight face, this is not just MD Anderson speaking, or as you say, Anderson, that this is kind of the setting a new bench for the new standard is a doublet.
Yes, I think we can at least say that of this regimen. And for me, for the future, it's um, whether it's this or something else. I think we my big hope for the future is that we need to revisit the localized uterine leiomyosarcoma systemic therapies, right? So that's one of the things with such great data in terms of response rate and overall survival with that adriamycin-based doublet. I do think we need to start thinking about adjuvant, so post-operative treatment, again, in uterine leiomyosarcoma. And I recognize that it's a challenge, that there's a lot of debate, that there have been former trials that have been negative with other chemotherapies. But for me, that's kind of where we can still cure patients, right? And if you look at the data currently, patients with uterine leiomyosarcoma, the median disease-free survival is only 2 years. So which means within 2 years, half of the patients who were disease-free, to whom we took out, resected their localized leiomyosarcoma, have a chance for cure. But 50% of them within 2 years recur. And if you look at long term, it's more like 70% of them end up having metastatic disease. And for me, that's where we as a field could have the biggest impact. And I whether it will be with this regimen or another, we need to revisit this question. And I know it's going to be a challenge, and I know there's going to be a lot of debate. And I, I see that coming, but I think we will need someone to help us lead this forward, someone who has a thick skin to not listen to what people will say. But I don't think that we can accept forever that based on trials that have not been able to accrue correctly, we're just accepting that 70% of patients are going to relapse from a potentially curable disease, and we're just not giving them anything after. So my wish is to push at least one of the combinations. Let's see what combination with adriamycin seems to be the most effective. But my wish for the next 5 to 10 years would be to push that, at least in this setting.
Great. And so people that are listening to, um, Elise always talks about adriamycin. Remember, it's
Doxorubicin, sorry.
doxorubicin. It's okay, because it is true. I do think, and to get to your point is, even though we're excited that the doublet for advanced metastatic disease with maintenance trabectedin is the new benchmark, and that no other histology to date has a doublet improving overall survival, there's still some unmet needs. And you highlighted the uterine situation where it is exorbitantly too much relapse to do nothing, but we have to be rational, tough skinned, or whatever to do the right study to make sure that if we're going to do something, that it's going to be meaningful and impactful. So we're on board. Love your energy. We'll see where this goes because it could be a national, international effort. And it has to be because we need to answer it fairly quickly. To that point, do you see any other unmet needs that you think that we should be working on? What are the unmet needs right now in LMS?
So I think there are a lot of different questions.
Oh, not a lot, because we've solved most. No, it
That's
sounds
true.
like we know we do have a lot. So, where do you think are some of the top three priorities of unmet needs?
Yeah. So I think there are several questions to be answered. I do think the maintenance question is a very actual question. So by maintenance, we mean like continued chemotherapy beyond the first 6 cycles of doxorubicin. Continued chemotherapy kind of throughout your disease, maybe a lower dose, more tolerable dose. And I think this coming from the LMS-04 trial is a very a current question to answer for the field, whether really kind of continuing chemotherapy throughout improves overall survival of patients, and that's for the advanced setting. Um, I I have an interest in moving also DNA damage repair treatments within the uterine leiomyosarcoma and actually also the leiomyosarcoma, soft tissue leiomyosarcoma field. I think some of the, precision oncology or targeted therapy has not been effective currently within leiomyosarcoma, but I think the DNA damage repair pathway space is definitely the next frontier that we need to investigate, and that we haven't been super good at it. We've been doing some attempts to it, but I do think we definitely see a signal in leiomyosarcomas that there is some DNA damage that could be targeted, and there are several efforts. So there was the olaparib and temozolomide combination effort. And then currently we have Dr. Haddock's leading a ETCTN trial with a Doxil and pepasertib combination that's also targeting the DNA damage that we're seeing throughout all leiomyosarcomas. The Europeans led a olaparib plus trabectedin trial, which was also interesting. I think, I don't know about the trial with pepasertib because we don't have the results. I think the olaparib combinations have been somewhat sending a signal, but somewhat disappointing. Now, if you look at it, olaparib was the first generation of PARP inhibitors, right? And so we now have next generation PARP inhibitors. They seem to be way more active. So this is the DNA damage repair field, I think might benefit only a subgroup of patients, but might really benefit some patients in terms of novel drugs. Yes, I think the maintenance in the advanced setting, and then for me, the DNA damage repair is one of the next frontiers. And something dear to my heart is immunotherapy. So trying to find other drugs. So there are some other immunotherapy drugs out there that are being developed in phase one. There are newer macrophage targeting drugs, drugs using dendritic cells that are in the phase one pipeline. And so we have a lot of those open here at MD Anderson in our phase one department, and we try to include as many leiomyosarcoma patients. And for some of those drugs, I feel like there's a real signal, and we'll see where it goes.
Well, you've touched on three big unmet needs. So if I would ask you, is that where you think we will be doing in the next 5 years for LMS? Is really pummeling hard on continued active treatment or some maintenance strategy? You talked about the role of getting into the adjuvant or neoadjuvant space. You talked about DNA damage as well as targeting novel ways to make it historically immunogenic dead zone to something that might be beneficial. So those four things, that's a lot there, Lise.
So 5 years, I don't know. I think maintenance is going to be. I can see that people are talking about it. There's going to be a trial on it. I'm pretty sure a cooperative group or something. I think someone's going to want. I know for sure that some things are coming, at least being discussed in different cooperative groups. I'm not the one who will answer that, but I will. I'll be excited in participating in those trials for sure. Um, might take more than 5 years, but because cooperative group trials, as you know, take just like 2 or 3 years to just get activated, and then we're going to have to enroll and then read out of the trial. So a bit more than 5 years. I'm my thing is I'm trying to work on getting an adjuvant uterine LMS trial going, which is hard, but I'm trying to get that working. And then the DDR, the DNA damage and immunotherapy. I mean, those are in phase one, and so we're going to see if we see some signal in phase one. We'll probably really have that data in the next 2 to 3 years, I'm hopeful, and then it probably will take a bit longer to actually read out as real novel therapies. So I think it's more of a 10-year plan. I wish research was quick enough for us to have readout on those things within 5 years. Um, Sometimes it's frustrating to see research move slowly when you have your patients in the clinic and you're like, I wish I could give you those things. But I think it's more of a 10-year plan than a 5-year plan. Um, but I'm hopeful that those things are people are working on them.
Absolutely. And as you know, the good thing is that it's a marathon, not a sprint. Um, but the patients that you see in the clinic help drive your passion, tension to move things quicker, faster. So we're excited about where LMS is going, and I think with your help and coordinating a lot of activities with other LMS centers in the United States and the world, that hopefully we can start to continue to move things along. And as you said, you didn't want to jump too early on the adjuvant because you didn't have the right combo. Now you probably have the right combo. Now the timing might be right. So there you go. So, Lisa, as we're and getting close here, there are some changes in your life that are happening. And I think maybe when this gets published, our podcast here, there might be changes that are happening in your life. And are you willing to comfortably share?
Yes. So I am right now, as we're recording, about to have a baby. By the time this gets published, I will have a little baby boy in my arms, and I am very excited about that.
So, well, we're wishing you all, you and your husband, the best of your new baby boy. Hopefully, everything will go fine. And then maybe when this gets published, that it would already have happened. So that's great. So, any additional comments you have, Elise, for us?
Um, I'd say we touched base on a lot of things. I want to tell everyone that it's a very exciting field and that we're all very collaborative. So anyone has any question on anything I'm doing, please send me an email, reach out. I will be very happy to explain my thoughts if I forgot anything. And it is a very exciting field, and we haven't talked about it much, but there are currently a lot of active trials in the leiomyosarcoma space. There are trials almost for every line of therapy, first line, second line, like every combination you can think of. So I think it's exciting, and we'll see the readouts of those trials. I can't cite them all, but we do have the adriamycin lurbinectedin in the first line. In terms of a second line, we have the gemcitabine docetaxel with or without the ADPEG Polaris trial, and I think those are the two major ones. There is the in later lines, we have the NCI trial by Dr. Chen, which is cabozantinib, ipilimumab, and nivolumab for patients with non-uterine leiomyosarcomas. And we do have Dr. Haddock's peposertib and Doxil trial. I'm probably forgetting a bunch of others, but I think those are the big ones that really have leiomyosarcoma focused arms, and others are less leiomyosarcoma focused. We do have the STRAS-2 trial also that includes retroperitoneal localized leiomyosarcoma. So I just wanted to advertise all of those trials in case people are seeing patients with leiomyosarcomas who are looking for clinical trials.
Well, at least, first of all, it is important that, the standard of care is enrollment in a clinical study. So that's number one. So if you can get somebody on a study, at least, you and I can't remember all the studies. We have a board that keeps track of it all too, because it's complicated, and we're very fortunate that centers like you and passion that you have is there. So refer down to MD Anderson or other sites as well, because they're available on clinicaltrials.gov. But please reach out if you have anything study-wise or patients that would benefit from going to MD Anderson. Elise, thank you for taking time today, and your enthusiasm and passion for your patients is infectious, as we would say. And as I said, all the best luck for you and the changes that are going to happen immediately this year, but looking forward to the next 5 to 10 years. So thank you.
Thank you so much for having me. This was very fun.
Thank you. Very good. So those that are listening, this will be coming out sometime in March of 2025, and we look forward to continued dialogues with other sarcoma interested people. So thank you.
Thank you for listening. Be sure to subscribe so you never miss an episode of SARC Talk. To find out more about SARC, please visit our website at sarctrials.org. To suggest a topic or for questions, please email us at sarctalk@sarctrials.org. Together, we can find a cure for all forms of sarcoma.